All right. Well, good afternoon, everybody. My name is Jessica Cecil. I'm the Education Coordinator at the National Aging Research Institute. Welcome to our online Seminars in Aging program. I'd like to begin by acknowledging the traditional owners of the land on which each of us are meeting today. For me, that is the Bunurong people, and pay my respect to their elders, past, present, and emerging. Firstly, just a little housekeeping regarding Zoom. At the conclusion of the talk, we'll have some time for Q&A. If you have any questions, you could submit them throughout the seminar using the chat tab, which can be opened at the bottom of your screen. Today, we'll be hearing from Associate Professor Tuan Nguyen. Tuan is a Principal Research Fellow at NARI and an Associate Research Professor at the School of Health Sciences, Swinburne University of Technology. He's also an adjunct associate research professor at Clinical and Health Sciences, University of South Australia. His current research lies in the development and implementation of national dementia strategies with a focus on low and middle income countries, culturally tailored interventions to improve lives of people with dementia and their carers, and medicines that can induce or worsen cognitive impairment and dementia. So today he's going to be presenting quality use of medicines in people with dementia. Where to go from here? Welcome, Tuan, and over to you.
Thank you very much, Jess, and the NARI's education team for inviting me to this seminars. And good afternoon, everybody, and thank you for coming to my talk, Quality Use of Medicine in People with Dementia, Where to Go from Here. So we already have the acknowledgements of the countries, and I also would like to acknowledge the Wurundjeri peoples of Kulin nations as the traditional custodians of the land on which we meet, and pay my respects to their elder past, present, and emerging. And I would like to extend those respects to all Aboriginals and Torres Strait Islander peoples throughout Australia, given that we meetings on Zoom and participants might come from different places across Australia. So there are three main parts in my presentations. First, I will provide you with the background, some definitions of rational use of medicine and medication-related problems. In the second part, I will present the findings of our narrative reviews on quality use of medicine in people with dementia. And finally, I will discuss the approach to improve quality use of medicine in people with dementia. So let's start with some definitions of rational use of medicines. Perhaps the earliest definitions of rational use of medicines is the one at the 1985 World Health Organization's the Nairobi Conference of Experts. And in that conference, rational use of medicine, which also known as rational use of drugs at the time, was defined as patients receiving medication that are appropriate to their clinical needs in doses that meet their own individual requirements for an adequate period of time and at the lowest cost to them and their communities. So think about rational use of medicines, meaning patients receiving right medications in right dose at the right periods of time and lowest cost. The Austrian definitions, also known as the quality use of medicine, provides a wider context for considering rational use of medicine by highlighting the place for non-drug therapies in management as part of its definition. It includes the judicious, appropriate, safe, and effective use of medicines, where judicious relates to the selection of management options, recognizing that in management of many health disorders, non-pharmacological therapies might be the best option. Appropriate relates to where a medicine is required, selecting the best option from a range of medicine available, taking into account the individual, the clinical needs, the risks and benefits, the comorbidities, and the cost. And quality use of medicines is also about the safe and effective use. This means ensuring the best possible outcomes of the therapies by monitoring the outcomes, minimizing the misuse, overuse, or underuse over time. So the quality use of medicines is a particularly important concept when considering people with dementia, because people with dementia are very vulnerable to medication-related problems due to their age, their cognitive impairments, and the presence of multiple chronic conditions. Medication-related problems include use of unnecessary or ineffective medicines, no use of medicine when they are needed, adverse drug reaction, use of medicines at dose too low or dose too high, and non-adherence. So to untangle the questions why medicines used in people with dementia is challenging, we conducted narrative reviews looking at the factors influencing quality use of people with dementia, medicine in people with dementia, and look for the approach to improve it. We systematically search the following database: Medline, M-based Cochrane's libraries of systematic reviews using the systems of quality use of medicine and its interchangeable terminologies such as rational use of medicine, rational use of drugs, responsible use of medicine, or medication-related problems in combination with dementia or Alzheimer's. And here are the results. The factor influencing quality use of medicine in people with dementia can be classified into two main categories: medicine-related factors and health system factors. So let's start with the medicine-related factors, the challenge of using medicine safely in people with dementia. Dementia is an umbrella term used to describe the syndromes of more than 100 underlying clinical conditions. It involves the deteriorations of cognition, behavior, and personalities, and the abilities to perform daily activities. It is progressive in nature, so during the course of in this person with dementia often experience multiple symptoms. In addition, dementia is a primarily a disease of old age. The global statistics show that more than 90% of people with dementia are older people, age 65 or older. And in the same situations in Australia, where only 8% of people with dementia had younger onset, leaving 92% of people with dementia age 65 or older. And we know that age is associated with multimorbidities. An Australian study showed that, on average, people with dementia in Australia had more than 4 coexisting chronic conditions. The progressive natures of cognitive impairments not only complicate the treatment of dementia, but also complicate the treatment of the other comorbidities. It is because cognitive impairments in people with dementia might lead to the treatment non-adherence or difficulties in communicating side effects. For example, a case report shows that a woman with mild Alzheimer's also had back pain because of osteoporosis fractures. So alendronate 10 milligrams per day was prescribed for her with instruction, taking the drugs with a cup of water and staying upright after injection. However, the cognitive impairments leading to non-compliance with the instruction and the difficulties in communicating side effects resulted in her continuing alendronate after the onset of the esophagitis symptoms. It was not until her admission to a local emergency department due to an acute onset of shortness of breath. An esophageal rupture secondary to ulcerations was detected, and she died when the ulcer eroded into a major vessels, despite chest tube drainage and operating intervention. The multiple symptoms, multiple morbidities means that people with dementia are often treated with multiple medication. The terminologies of polypharmacies. More than 90% of people with dementia in resident healthcare facilities have been found to use more than 5 medications concurrently. And the figure was 68% in memory clinics, 43 to 52% in community settings. And on average, people with dementia in resident healthcare facilities use 10 different medicines at the same time. The multiple medicines used lead to an increased risk of drug interactions, with the chance of drug interaction being 6% when 2 medications are used together, increased to 50% when 5 medicines are used concurrently, and 100% when 8 medicines are used concomitantly. The drug interaction can increase the toxicities of individual medicines, leading to an increased risk of adverse drug reaction. It also can reduce the efficacy of individual medicines. We know that more than 90% of people with dementia in resident healthcare develop changed behaviors. And 60 to 70% of people with Alzheimer's dementia type had incontinence. Pharmacological therapies for these symptoms or these comorbidities include antidepressant, antipsychotics, antimuscarinics, and many of which have high anticholinergic and sedative properties. People with dementia are also often being treated with cholinesterase inhibitors to delay the cognitive impairments. But when cholinesterase inhibitors are used together with anticholinergic agents, their efficacy can be reduced due to antagonistic mechanism. A paper in American Journals of Psychiatry by Low and Tuan show that the long-term concomitant use of donepezil and anticholinergics led to a significantly faster decline in cognitive function compared with donepezil use without anticholinergics. Despite this evidence, the prevalence use of the 2 agents concomitantly is very high, both in low and middle income countries. For example, in Vietnam, my studies show that nearly 40% of people with dementia in a national dementia care plan use the 2 medicines together. It was the same in high income countries, like in US, the figure is 37%, and in Australia, 44% of people with dementia in resident healthcare use cholinesterase inhibitor and antipsychotics concomitantly. People with dementia, most people with dementia are older people, thus having age-related changes in pharmacokinetics that might negatively affect their medication use. When people age, there is a progressive reduction in the total body waters and the lean body mass, leading to a relative increase in body fat. It is more significant in people with dementia than the general population, because people with dementia are more likely to experience weight loss compared to the control. The age-related changes in body compositions lead to a reduced volumes of distributions of polar water-soluble medicines, leading to increased serum levels of those medications, resulting in a higher risk of medicine toxicities, especially for those medicines with very narrow therapeutic index, such as digoxin. On the other hand, the age-related changes in body compositions also lead to increased volumes of distributions of non-polar lipid-soluble medicines, leading to increase the half-life elimination time for those medications. Compared to the healthy older people with dementia, on average, have 10% lower levels of albumin. Albumin is plasma proteins to which some medication bind. This means that compared to the healthy people, older people with dementia have a lower levels of medicines bound to plasma proteins, thus leaving a higher concentrations of medicines available to exert their therapeutic effects. And this potentially lead to the increased risk of adverse drug reaction. The integrities of the blood-brain barriers in people with dementia also can increase the risk of adverse drug reaction. We know that the blood-brain barriers have the functions of limiting access of hydrophilic and large molecules into the brain. The efflux transporter P-glycoproteins at the blood-brain barriers also have the protective functions of transporting selective substances immediately out of the brain. When people age, the permeabilities of the blood-brain barrier significantly increase, and is further increased in people with dementia compared with those without dementia. And research has found that the P-glycoproteins activities has been impaired in people with dementia. So these changes mean that more medicines can enter the central nervous system and remain there at a higher levels, leading to increased risk of adverse drug reaction. And we also add the age-related changes in pharmacokinetics, like the reduce in liver size, reduce in liver blood flows, leading to reduced metabolism, the phase 1 of medicines that with a high extraction ratios via liver, or reduced renal clearance, leading to accumulations of renally excreted medicines. So those changes have potential to increase the risk of adverse drug reaction. There are also age-related changes in pharmacodynamics, whereby the interactions of medicines and the receptors of the biological sites of action is altered with resultant clinical effects in people with dementia. The changes include other sensitivities to certain class of medication. For example, people with the Alzheimer's disease was found to have much greater response to anticholinergic medications. So the age-related change in pharmacokinetics and pharmacodynamics have made people with dementia more susceptible to side effects of medications and more sensitive to the effects of medication on cognition. Also related to medicines, we need to consider the evidence for the efficacies of medicine used to treat different symptoms of dementia. Today, apart from aducanumab, which was approved by the FDA as a therapy focusing on the underlying causes of dementia, actually of Alzheimer's disease, last year in the US, in a very controversial decision that led to the resignations of the 3 advisors to FDA in the absence of the evidence of efficacy of the drugs. The current management strategy focusing on the delaying cognitive symptoms of dementia, or managing the behavioral and psychological symptoms of dementia, or managing the physical symptoms of the disease progression. However, the research shows that there is a lack of understanding about the benefits and potential side effects of the medications among healthcare professionals. So let's start with the medication for cognition. They call cognitive enhancers. The cholinesterase inhibitors is the first group of cognitive enhancers. And clinical trials found that only 1/3 of the patients who use cholinesterase inhibitors actually responded to the medication. And among those responding to the medication, the benefit is modest. When activities of daily living was measured as outcomes, use of cholinesterase inhibitors is associated with stabilizing or slowing the decline in activities of daily living and global change. But the effect size is small and of uncertain clinical importance. Whereas cholinesterase inhibitors have a significant cholinergic side effect with 2 to 5-fold increased risk of gastrointestinal side effects, neurological side effects, cardiovascular side effects, and general side effects. There is evidence that the cognitive enhancers are being used in a population that are less likely to benefit. Up to 1/3 of cholinesterase inhibitor use in long-term care setting is either initiated or continues inappropriately, and the same situation for memantine. 1/3 of memantine use is for an unsupported indications or continue inappropriately. So the initiating, continuing, or stopping cognitive enhancer need to be individualized with periodic reviews taking into account both the perceived benefits and the side effects of the therapies. These medications need to be considered for this prescribing when dementia has progressed into the severe stage, and the clinical practice guidelines for the prescribing anti-dementia medicines have been developed in Australia. How about the medication for change behavior? We know that more than 90% of people with dementia in long-term care settings develop the change behaviors, and 76 to 87% of people with dementia in nursing home use psychotropic medications, including antipsychotics, and the prevalence of antipsychotics use in people with dementia in nursing home in UK was 48%, and in US was 33%. Whereas psychotropic medications have modest efficacies in change behaviors, with up to 20% of psychotropic users deriving some benefits from the treatment. And among those with the treatment benefits, the effect size ranges from 0.1 to 0.2, which is lower than that of some non-pharmacological therapies. Whereas psychotropic medications use is associated with an increased risk of serious side effects, including death, stroke, other cerebrovascular adverse events, and gait disturbance. Use of antipsychotics in people with dementia was found to be associated with decreased quality of life and well-being, and increased the cognitive impairment. Therefore, clinical guidelines suggest that psychotropic medication should only be used when social interventions are exhausted, when the symptoms are psychotic in nature, when there are severe and complex risks of harm, and when there are comorbid mental health conditions. And if we use psychotropic medications to manage BPSD, we need to start at low dose, go slow, and for limited periods of time, with regular reviews of possible discontinuation. One of the reasons why psychotropic medications are used as a first-line approach in case of BPSD is the fear of deterioration of the symptoms, especially in long-term care settings, where people with dementia often enter the facilities with the medicines already in place. However, seizing the chronic antipsychotic medications can be successfully undertaken without detrimental effects on behavioral, functional, and cognitive status. Of course, there is a small group of patients with more severe neuropsychiatric symptoms at baseline could benefit from continuations of antipsychotics, but these benefits need to be weighted against the side effect profile. People with dementia mainly are older people with multiple chronic conditions, so they are vulnerable to the potentially inappropriate medication use, where the risk from medication use outweighs the clinical benefits, or where there is a safer alternative option available. Research shows that the prevalence of potentially inappropriate medicine use in people with dementia range from 10% to 56%, higher in the resident escape capacity than in community settings. But more recent studies also show a higher prevalence, 60 to 64%. The use of potentially inappropriate medicines was found to be associated with an increased risk of adverse drug reaction in people with dementia, increased risk of hospitalizations in people with dementia, and increased the mortalities. So now I would like to move on the second group of the factor influencing quality use of medicine in people with dementia, the health system factors. The first health system factors is the lack of an evidence base to guide prescribing for people with dementia, given the fact that people with dementia often be excluded from the randomized control trial, from the clinical trials. The clinical practice guidelines on dementia rarely address multimorbidities, despite the fact that people with dementia often have multiple chronic conditions coexistent. A systematic review in 2015 of dementia practice guidelines identified 12 moderate to high quality guidelines, of which only one from Canada mentions about multimorbidities. And clinical practice guidelines for other chronic conditions also fail to recommend what to do with people with dementia. So the treatment decision is left to individual practitioners who might encounter a conflicting practice guidelines. And I like the pictures of my colleagues from University of South Australia when she showed the doctors scratching his head, thinking about a person with dementia, like standing in the middle of the intersections, and she's going to be run over by different conflicting treatment guidelines. Another health system factors is a lack of appropriate undergraduate and postgraduate curriculums on dementia for doctors and nurses, and very little training in dementia management in primary care and in home care, leading to the skill and knowledge gaps for dementia management among the primary healthcare workforce. Only 1/3 of GP in UK in a survey believe that they had received sufficient basic and post-qualification training to diagnose and manage dementia. And research also show that the GP lack understanding of the benefits and potential side effects of antipsychotics, whereas the nurse was believed to have unfounded high expectations of the effectiveness of antipsychotics. And these skill and knowledge gaps, the belief and expectations lead to the inappropriate use of medication, psychotropic medication, especially antipsychotics in resident care. Literature already shows promising results for non-pharmacological therapies. But the nature and the range of these alternative options is not known by many healthcare professionals. Lack of abilities across the primary care workforce to advise on or deliver these non-pharmacological interventions also reported as a reason for inappropriate use of this medication. Other health system factors include the staff and resource limitations among the care home, the policy and management issues, the inadequate reviews practice, and communication barriers, all leading to the inappropriate use of the psychotropic medication. The multimorbid patient with dementia needs a coordination of care to ensure appropriate care, but failure to coordinate care between the OS psychiatric, geriatric medicines, and neurologists and primary care service have been reported in the UK. So now, after reviewing the factors influencing the quality use of medicine in people with dementia, I would like to discuss the approach to improve quality use of medicine in people with dementia. Different people with dementia have different manifestations of the symptoms, depending on the severities of the disease, depending on the type of the disease, on the personalities of the person. So we need to look at the patients at a holistic person rather than look at the individual disease in person with dementia. Therefore, any treatment for people with dementia need to be individualized, taking into account the physical, personal, familial, economic, and social environment. The personhood of people with dementia is the unifying themes in person-centered care. No matter what the stage of dementia, evidence-based clinical practice guidelines suggest that non-pharmacological therapy should be the first-line approach for symptomatic treatments of behavioral and psychological symptoms of dementia. Apart from improving different symptoms, non-pharmacological therapies can also contribute to improve quality use of medicine in people with dementia. For example, this crossover trial of music therapies found that increased administration of psychotropic medication occurs significantly less often during the music therapy periods than during the standard care periods. Other studies like the whole things antipsychotics used in long-term care setting with the education for GP, for nursing staff, and for families can sustain the antipsychotics prescribing in 75% of the residents over 12 months without re-emergence of behavioral and without substitution of the medication. A number of the aged care facilities already developed the framework for them to tackle the unmet needs of people with dementia, looking at the people with dementia holistic before thinking about the pharmaceutical interventions. For example, framework co-PEP by the Juniper's Elimata, showing that they teach their staff that they need to consider interventions to assist with the unmet needs categorized as the physical, physiological, such as bowels and urines, pain and discomfort, hunger and thirst, or environmental factors such as noise, other residents, activities in the areas, room temperatures, psychological factors such as concerns about families or self, anxiousness, fears and safety, and social factors such as social interaction, communication, and companionship. Before thinking about the last resort of pharmacological therapies and physical restraints. The Austrian National Strategies for Quality Use of Medicines have provided 6 building blocks to support any quality use of medicine endeavor. And they include the policy development and implementation, felicitations and coordination of quality use of medicine initiatives, provisions of objective information, and assurance of ethical promotion of medicines, education and training, provisions of services and appropriate intervention, and strategic research, evaluation, and routine data collection. And we apply that framework to make the recommendation for improving quality use of medicine in people with dementia. First, at the national level, consistent with the WHO recommendations, a national dementia plan that incorporates the strategies for quality use of medicine in people with dementia is needed. At the facility levels, there needs to be policy in place to make quality use of medicine for people with dementia a clinical governance priorities. So mechanisms that facilitate, coordinate, and support initiatives to support quality use of medicine in people with dementia at state, regional, and local levels are also required. For the local system of clinical governance to support quality use of medicine in people with dementia, reliable information on the levels of medication-related problems in people with dementia is needed. Therefore, local audits with individual health services to measure the levels of medication-related problems and issues in people with dementia, with data fed back to prescriber to generate a plan for improving medicine use in people with dementia, followed by subsequent implementation and evaluation would assist. Standardized data collection methods are recommended in local audits to enable the collections and collation of regional and national data. Leadership plays a critical role in coordination of the activities and initiatives. The strategies for quality use of medicine in people with dementia should be a component of a national dementia plan, with the structure put in place for the implementations of the initiatives. So there needs to be a position of a national clinical directors for dementia to take these leadership roles at a national level. This person will need to work with national and local clinical audit structure and medical directors and pharmacy in primary healthcare services to develop an audit to generate baseline data across the nation. The audits need to be repeated annually to evaluate the progress of quality use of medicine in people with dementia, which will be reported to the Ministers of Health and Aging by the national clinical directors for dementia. Clear ambitious but realistic goals for the reductions of inappropriate medicine use in people with dementia should be agreed and published locally following the completion of the baseline audit. These goals should be reviewed annually at all local, regional, and national levels, with information published annually on the progress towards them at each level. Thus, to provide objective information for prescribers, we need to develop evidence-based guidelines for initiation, maintenance, and cessation of medicine for symptomatic treatments in people with dementia. These guidelines need to incorporate recommendations for treating those with common or conflicting comorbidities, and best practice need to be tailored to different common types of dementia. Knowledge and skills in diagnosis and management of dementia of the GP and other healthcare professionals need to be consolidated through improved education and training. We need to develop appropriate graduate and continuing professional development curriculums for both GP and other healthcare professionals working in care home and hospital setting to develop skill to manage complexities, comorbidities, and severities of dementia. The education should include elements of geriatric and OS psychiatry, including the essentials of dementia care. Developments of a national vocational qualifications in dementia care for the working with people with dementia, such as nurses or care staff in care home, is also needed. And the curriculum for education and training need to incorporate care strategies that enable holistic care, challenge of caring for people with dementia, and the alternate option for non-pharmacological therapies. Given the shortcomings of the current healthcare system in developments and provisions of healthcare for people with dementia, a more effective models of care of people with dementia need to be trialed and implemented. While improving knowledge and skills for GP and social care staff to operate undergraduate and postgraduate medical and nursing curriculum, and in vocational training is a long-term strategy. It takes time for this development to develop and to have effects. So, to address the pressing problems of inappropriate medicine use in people with dementia, solutions with immediate impacts are needed. The primary health care services therefore need to immediate direct support from specialist services, such as specialist older people mental health services, using commission invasive services through which primary healthcare workers can quickly learn and build their knowledge and skill in the assessment and care of people with dementia in situ. And as an expert in medicine, pharmacists should play a significant role in quality use of medicine in people with dementia through a full set of integrated pharmaceutical services. This includes medicine and health education, medication reconciliation, adherence services, and medication review services. Given the complexities of medication management in people with dementia and the need for individualized patient-centered care, pharmacist information service for other primary care providers is also needed. And a number of studies have demonstrated that the usefulness of pharmaceutical service in supporting quality use of medicine in people with dementia. And finally, we need to develop a strategic dementia research program that incorporates research into the support quality use of medicine in people with dementia. The focus should include the clinical and cost effectiveness of non-pharmacological therapies for symptomatic treatments of dementia. Of course, we also need to continue to look for the treatment that target the underlying process of dementia. Also important is research on the potential efficacies of other alternative pharmacological treatment. This will provide evidence base for the implementations of services and intervention proven to support quality use of medicine in people with dementia. And apart from data generated from annual clinical audits, as mentioned before, then to support the programs of dementia research, a national dementia database such as national dementia registries need to be established, and we in Australia we have the ARPANET process with the one component to develop the dementia registries. A national dementia database will provide the data for the policy making process and to support research capacities in quality use of medicine in people with dementia. So, in the conclusions, given the complexities and the challenges of use of medicines in people with dementia, we need a multidisciplinary, patient-centered, integrated, and coordinated model of care for people with dementia, where the person with dementia and their carers at the center of the care, supported by a fully integrated different primary care network, the general practitioner pharmacists, allied health professionals, and home care and community carers. And we need a designated care coordinators, which could be anyone in the primary care network. And the practitioner would be responsible for integrating the patient care into the secondaries and tertiary care network. So by this note, I'd like to conclude my presentations. Thank you very much for the attention, and it's time for Q&A. Thank you.
All right, well, thank you very much, Tuan. We now have some time for Q&A, so if you have any questions, please submit them now through the chat function. Alternatively, if you'd like to ask a question in person, you could turn on your camera and your microphone now, and we'll be able to call on you in turn. So having a look in the chat, we've got one question come in from Natalie, who asks, regarding your slide on polypharmacy, was that in relation to Australia only, or were those worldwide statistics?
Yeah, that is the international data, because you know that the findings of the scoping reviews. So we look at all the published evidence across the world.
Fantastic. And regarding polypharmacy, is this generally more common? I believe the stats on that page were for general community. Is polypharmacy found to be more common in people living with dementia as well?
Yes, it's correct.
Fantastic. Well, I had one question down here. I noticed on one of your slides that Canada was identified as one of the only countries that have guidelines that include multimorbidity included in that. Do you have any idea as to whether or not this is translated into better outcomes?
Actually, you know, so we only look at the vast systematic reviews, and it is quite old systematic reviews in 2015. And now we just recently finished the development of the clinical practice guidelines for use of psychotropic medication in people with dementia in Australia, led by Professor Simon Bells in Monash University. And the guidelines are already out there for the public consultation. So that first I have to acknowledge that is the quite old systematic reviews 6 years, 7 years ago. I didn't follow up to look for the better outcomes from Canada based on us, because to evaluate the policy or guideline impacts at a national level is quite difficult, given a lot of other confounding factors. So I didn't follow up with that research ideas.
Thank you, Tuan. Well, if we've got no further questions coming in, would you all please join me in thanking Tuan with your clap reactions?
Thank you very much for having me, Jessica.
Yeah. So everyone, next fortnight, Anne Tiedemann will be presenting Can Yoga Prevent Falls in People Aged 60 Plus, an update on the progress of the NHMRC funded Successful Aging Yoga Trial. So please join us next fortnight on Tuesday, the 10th of May at midday. And thank you very much for attending our Seminars in Aging program.